Okay, welcome everybody to MG Canada presents Dr. Katzberg, who is our medical advisor, and he's going to do a talk today.
Okay, great. Thanks, Linda. I'm just going to share my screen here. So as I was mentioning, I do have some slides. However, very few because I want to leave as much time for interactivity and time for questions. I think the main purpose of these sessions is to have a chance to have a dialogue and ask questions. So I'm happy to share any of the insights that I have from our group. I'm also very happy to be back with this group again, although it is Zoom. I do remember many years ago, we've done some of these local sessions in Toronto up on St. Clair Avenue in a small room there. And we've done some of these online. So it's great to be back with MG Society. And I see a number of different people online, and it looks as diverse as our MG clinics. So everyone, all ages and genders. We at Toronto General, where I work, we also even see pediatric patients transitioning over. So it's nice to see everyone online there. So just a little bit about me. I'm a neurologist, neuromuscular specialist. I work at the University of Toronto at the Prosserman Center at Toronto General. I've been here, first came here over 20 years ago from Vancouver, where I started my training. And I work here with a group of physicians, nurses, research coordinators, technologists, a whole team really that's dedicated to diagnosing, following, managing, and treating patients with neuromuscular diseases. And one of the biggest things that we do is manage Myasthenia Gravis and other neuromuscular junction disorders. So I think the focus of today, I talked to Tony Watkins about this, and he had asked me maybe to share some insights on some of the new therapies and new treatments that there are there for MG, because certainly there's a lot of interest in this, and there's a lot of excitement about some of these treatments. There's also, of course, a lot of practical aspects to accessing these treatments in Canada. So we can talk all about this in the next little while. And I think at this, like I said, I have a few slides. Feel free to maybe raise your hand on the Zoom, put a question in the chat, or we can have time at the end also for the questions. So I like this slide. I'm not going to talk a little bit about the existing therapies for MG, but you cannot just talk about new therapies without speaking about what's there and what's current and what's been used for many, many years now with great success to manage MG. And this slide, I think, captures the evolution of that over time. You can see here as far back as the 1920s, when the mortality from myasthenia was very high, and that's why it's called Myasthenia Gravis. And that is because things like ICU care, ventilation support, and even some different early versions of mestinon, as you know, or pyridostigmine, you can see here neostigmine, and some other treatments had just been developed just over 100 years ago. And once antibiotics became more common, the infections associated with MG started to also be able to be treated. And throughout the decades, and starting in the 20s, it was started to be observed that thymectomy, or removing the thymus gland, was not only helpful for people with thymomas, tumors of the thymus gland, because that was where the antibodies to the neuromuscular junction are thought to originate in some cases, but also people without thymic tumors that may have just had an enlargement of the tumor or of the thymus gland, or maybe even patients without any sort of enlargement. Taking out the thymus was being observed to be very helpful. So you see here on the graph in the middle there, thymectomy. So all these help to improve the mortality of patients with myasthenia, which is in the light blue line. And then starting in the 50s and 60s, it was recognized that immune therapies like steroids and early versions of that were called ACTH. And then, of course, the more recent you're familiar with is things like prednisone, were starting to be used. And that's really when the immune theory became very much more apparent in the 60s and 70s, and that further improved the outcomes. And then over the last few decades, there was a lot of efforts at trying to replace steroids with others. We call them steroid-sparing agents. You see here azathioprine, cyclophosphamide, cyclosporin, and mycophenolate mofetil. So some of these, you're maybe more familiar with some of the trade names, but these are the ones that were used to replace the steroids. And then again, in the 80s and 90s, it was recognized that IVIG, so immunoglobulin antibodies from healthy donors, also have a positive immune effect in patients with myasthenia and help to avoid crisis and could be helpful. Now, the challenge is that you see in the red line here that the light blue line is mortality, but the red line is really an estimate or a hypothetical representation of morbidity, which means not just mortality, survival from myasthenia, but how someone is doing in terms of their function. And you can see that although we've done very well at making sure people don't have very serious fatal outcomes from myasthenia, there's still a gap here that exists in our ability to manage patients with MG in spite of all our treatments that we use day in, day out. And I should mention also here plasma exchange, which was also used starting probably even just before IVIG as a rescue medicine as well. Although that's quite limited in which centers have capability to do plasma exchange. For example, in Toronto, there's only a couple of hospitals, St. Michael's and here at Toronto General, where we have this availability. So these are the existing treatments. And I'm not going to talk too much about those treatments, as I mentioned, but perhaps when we're talking about new therapies, one thing that has been used a bit more over the last 10 years or so, and when I say new treatments, I think we're not just talking about what's been out there in the last few months or year, but really new treatments being things that we've used more over the last decade or two. And one thing that we've used, and many might be familiar with, is using IVIG a little bit more chronically, meaning we might not just use it for a rescue, but use it to maintain someone. Although this treatment is not very convenient because it has to be given in hospitals. It's an intravenous immunoglobulin, has to be administered by a nurse in the hospital under a monitored setting. However, sometimes we don't have a lot of options, and someone might be very active with myasthenia and, for example, not be able to take high doses of steroids because of side effects or reactions or allergies or intolerance. And yet we have to maintain someone and keep them as symptom-free as possible. A lot of times also patients are waiting for surgery, for thymectomy, or need to get through a particularly difficult period of any other medical conditions that might be active. So there is situations where we use IVIG in the more chronic setting. And this is one report here of our experience at Toronto General using chronic immunoglobulins as maintenance therapy. And it wasn't just IVIG. In the last number of years, we've used a subcutaneous immunoglobulin, and that is a form of IVIG, the healthy antibodies that is patients can administer themselves, and the name of that is SCIG. And that was used successfully in our clinic to manage some patients with minimal issues with transition. So that is something that we've been used and observed. However, there isn't really a lot of high-level evidence, meaning a lot of proof and clinical trials that have shown that subcutaneous, this self-administrative form of IG works in MG. So we're trying to collect as much information about this as we can. And this is one study that we have ongoing that just completed in December at Toronto General, taking 30 patients with myasthenia and trying this subcutaneous immunoglobulin, self-administered, and seeing if patients are able to do better or maintain on this therapy for 6 months. And comparing that to a group of patients that we also wanted on sub-Q immunoglobulin over 3 months, but really we started with the IVIG and transitioned them. And the reason we did this because it's not known really at this stage which option is better. Should you just go to sub-Q alone or start with the IVIG and then switch. So that's the very reason we did this study. And there's two other studies out there on subcutaneous immunoglobulin and myasthenia, one out of United States with the colleagues that we've participated in, and one out of Edmonton, Dr. Siddiqui, at the center there. And they both use different strategies of administration. One just used the subcutaneous alone over 6 weeks, and one used IVIG switching to subQ. And we really didn't know which was better because no one had done a comparison. So this is something that's ongoing, and we should have the result from this over the next 6 months or so. So I think the point of this slide is just to show that in addition to rescue IVIG, we have used immunoglobulin for myasthenia more over the last decade or so, usually as bridging therapy, but in some cases to maintain patients' stability. It is a challenging long-term option because coming to the hospital every month for IVIG for years and years is not easy. That's why the idea that subcutaneous immunoglobulin, which can be done at home, might be a little bit of a better option. There's less side effects. However, that's also a challenging, ongoing, long-term therapy to consider. So we have to factor all these in. This is a slide that is really just a summary from a review of all the other new therapies. So I've talked about steroids, steroid-sparing agents, and IVIG. So these are all the other new therapies in terms of categories. So I think it's a nice slide because it kind of has it all in a little flow chart here, and it groups them according to the mechanism. So I'll talk a little bit about at least three of these. The complement inhibitors, we'll talk about that. Eculizumab, that is available in Canada and administered in some patients. And the other two medicines, zilucoplan and ravulizumab, these are other complement inhibitors. Those have not been routinely available in Canada yet. And all of them have challenges with access. So we'll talk about that as well. Another class of medicines we'll talk about is the FC receptor inhibitors. So this is a very novel immune mechanism that uses the body's own recycling transport system that's available in the body for all sorts of molecules, and takes advantage of that recycling mechanism to alter the immune system enough to help reduce antibody levels and have a positive effect on myasthenia. B-cell inhibitors target another one of the immune aspects of the immune system, the B cells, so it is a different mechanism than these others. And this has also been now available in Canada for other diseases and has been used in myasthenia, rituximab, and there is some other ones as well. So this has been around a bit longer, but there is some updates to guidelines in relation on how to use these. And then the last two here are really much more experimental. T-cell inhibitors. So you saw the B-cell inhibitors, there's T-cell inhibitors. I won't go into great detail on that, but this is what's known as CAR-T cell therapy. It's quite involved at targeting these T cells. This has been used in some cancers. And then the final group here you see is hematopoietic stem cell transplantation. So this is really a very aggressive way to reset the immune system by really replacing all the stem cells in the bone marrow with new stem cells and really resetting the immune system. And that has been tried in myasthenia in a very limited way. Not a lot of high-level evidence on the last two therapies, so I won't present much on that and focus on the first three. So let me talk about the B-cell therapies first, just because that has been around a bit longer for myasthenia. You can see it here as early as 2016 in the myasthenia guidelines from the American Academy of Neurology, where it was mentioned that B-cell treatments could be considered early on in a particular type of MG. So many in the room know about MuSK MG, and that is about 5% or so of myasthenia. And because of the way that MuSK affects the body, this type of strategy, the B-cell treatments, were found to be very effective in this condition through particular kind of antibodies or immunoglobulins that are affected, the IgG4 type antibodies. And in 2020, an update to the guidelines and then a consensus update did highlight that perhaps rituximab, this medicine, could be also considered not just in the MuSK-MG, but in other types of myasthenia. And there's now been some recent trials as well showing that maybe a lower dose of this therapy, usually it's given every week for 4 weeks and then repeated usually around every 6 months or a bit more in some cases. But these strategies can work well for myasthenia. It tends to be a very strong method of lowering the immune system. It's very challenging to reverse this once it's given. So there has to be some caution in certain cases, particularly if someone might be at risk for infection, of administering these. But it is used in myasthenia, particularly in MuSK, as I mentioned, in some cases of refractory myasthenia, where there may be lack of response to other therapies. And the reason I put up here turning off the faucet, because one way to think about this treatments is turning off the B cells, which are where the antibodies come from. So that's one way to think about it, is turning off the production of the antibodies by affecting the cells that actually make them. So that's why it's a strong immune suppression, because it really turns off the B cells and they don't really come back for usually a number of months, usually, as I mentioned, at least 6 months, which has benefits because you don't have to continue to give the treatment. However, it's a challenge in that you cannot reverse the treatment once it's given for a period of time. The complement drugs, so just going back to the graph that I showed you, see here, so the B cells are right in the middle there. Rituximab is one of the B cell treatments, and there's others as well. The far left here, you see complement inhibitors. So what are those? So this is a completely different mechanism. In myasthenia, you have the challenge at the neuromuscular junction. You can see here the top light yellow is the nerve, and the pink is the muscle. And this acetylcholine, the green molecules here usually are released from the nerve and arrive at the pink receptors on the muscle membrane junction and then contract the muscle. However, when you have these interfering antibodies, in the blue, the acetylcholine receptor antibodies, AChR, that's also how we diagnose myasthenia. We often will test for that. These interfere with that transmission. And not only do they block the antibodies, but they activate something called complement. And complement will then damage the muscle membrane, not just in the long term, but sometimes acutely as well. And on the right here, you see all the little molecules involved in this complement system. And by blocking some of this, you can prevent the damage. And there's some studies as early as 2017, you can see here, that showed that this was an effective therapy in myasthenia gravis and has been used in cases of MG. The restriction being that this was tested in patients with refractory myasthenia, meaning really people were not responding to a number of other treatments such as steroids or IVIG or steroid sparing agents, and so this needed to be used. So going to the group of drugs in the second column, this is the FC receptor inhibitors. And as you can see, there's the good news about all these therapies that there's not just one. There's, and often, many cases, multiple of these types of therapies that are being developed, oftentimes by different companies, which is good because it generates competition and more availability and options for patients. So of course, we're still at the very early stages, but there's a lot of interest in developing these treatments. So the first one really that now is starting to be used for MG, it's been used in the US and it's starting to be used here in Canada. It's called efgartigimod. This is an FC receptor inhibitor. And I told you the mechanism is that it uses the body's recycling mechanism and actually uses it to affect the immune system. There's a lot of different reasons to recycle things in the body. One of them would be to actually recycle the antibodies that we have to protect us against infections. And those also have to be recycled. They are taken up, you can see here in the panel, in the cell, and then they are recycled back out into the circulation. There's other things that happen through this mechanism that are not recycling. Sometimes these molecules are transported across the membrane. Think of maternal to fetal nutrition. So sometimes nutrients have to get from the maternal placental side to the baby. This is the mechanism by which this happens. So there's a lot of different natural reasons why this kind of transportation, either for recycling or across membranes, happens. And if you block that in a very targeted way, it turns out that if you do it in a very specific way, you don't affect the natural mechanisms that the body needs, but you could block recycling of some antibodies, so that some of the bad antibodies that are thought to be present in MG, so that you lower the effective circulating antibodies in the blood, and then they're less available to damage the muscle. And so because of this lowering of these bad antibodies in the circulation, you can think about that as the same thing that happens in plasmapheresis. I mentioned that treatment, and that essentially is like a washing of the blood and a filtration system, effectively, like dialysis, where you wash out the pathogenic antibodies or the bad antibodies in the circulation. And usually that requires a big machine and hospital-based treatments, but this medication allows this to be done through different infusion therapies. So that's why people sometimes call it the chemical plasmapheresis. And you can see in the left here, the antibodies drop from the far left. You can see the antibodies drop over a period of a few weeks, and then before they get restored after treatment with this. And this is exactly what happens with plasmapheresis, or the washing of the blood. So it really offered a very new way to affect the immune system in a safe way. And there's been many studies now that have showed that this is helpful in MG and can be used. So here is a summary table of some of the different therapies that I've mentioned. It just tells you a little bit about what type of treatment there are, their antibodies, what their target are, what indication there are. I told you some are for refractory myasthenia, some are for MuSK myasthenia, some details about the dosing, and some safety concerns. And I think all of them have been shown to be quite safe in myasthenia. Some of them require some vaccinations. For example, all the complement therapies, a lot of the complement therapies, I should say, require meningococcal vaccination, because there can be a risk in some of them of developing that. And some of the B-cell treatments, as I said, have a risk of some serious infections as well. Some of the newer therapies I mentioned have less severe side effects and concerns. All of them have infusion-related reactions that can happen, like IVIG, including headaches and other kind of chills and malaise. However, tend to be well tolerated, at least in the studies that have been out there. So I'll pause there and take questions. So hopefully showed you that over time, our management of MG has improved. And we use steroids, steroid-sparing agents, plasmapheresis, IVIG, and now we're trying sub-QIG. And some of the really new therapies use novel mechanisms, shutting off the antibodies, preventing the damage at the junction, and reducing the circulating antibodies, just like plasmapheresis does. And all these therapies are now either being tested or already have been shown to be helpful in MG, and that's a very exciting time for us as treaters and for patients as well. So I'll pause there and happy to take questions.
So if you guys can put up your hands if you have a question, so nobody's talking over somebody else.
I'll start. I am Alistair from Ottawa. I'd just like to mention that I'm in a clinical trial for nicolibimab, one on the chart. For me, I've been on it since April of last year, and it's going very, very well. I don't think it's going to be on the market for a number of years, however, but for me, it's a major improvement. Was on Plasma X for 5 years, and this is the same sort of thing, except the infusion takes 10 minutes with a flush of 5 minutes, and then a wait of a half an hour for security reasons, because it's a trial, but it's going very, very well.
Great, thank you for your comment. So a lot of important points in what you said. First of all, there is a lot of trials active now, which are great. I think the challenge sometimes with the trials is a lot of them are placebo. So of course, there's a 50-50 chance of getting it in the cases. But if you're lucky enough to have gotten the medicine, you may notice a significant effect. And of course, if you then transition into what's called an open label phase, you may end up actually getting the drug and being aware that you are.
Yeah, this was a double blind. I'm pretty sure I was getting the products in the double blind section. I've now been on the open label for 2 months, getting it every 2 weeks. And then after a year, I go for once a month. And then the guarantee on the contract I signed is that I get the product until it goes on the market. But because it's a worldwide product, I don't know what that really means definition wise. Once it's approved in Canada, it has a DIN, then I don't know, but I'll worry about that. But it's a couple of years away. But it's good. It's very good.
And just to be clear for the group, this is one of those FC medicines. So as you said, it makes sense if you were on plasmapheresis and that worked for you, that this, because it's similar to plasmapheresis, is a natural thing to try. And so I'm glad that it's helping you.
Thank you.
Okay, Lena, she has her hand up.
Thank you. I have two questions actually, and I'm new to this, so I'm sorry if they might be a little bit naive. The chemical plasmapheresis, you said it kind of washes out the antibodies, but from what I understood from research and what my doctor has told me, the antibodies or the level of antibodies doesn't necessarily correlate to your symptoms. So how does it actually work when you wash out the antibodies? You could still have symptoms?
That's a great question, because many times people want to know, how is my MG doing? And when we did the diagnosis, we did these antibodies and we got a level. So can't we just check that? And despite many efforts over many years, the acetylcholine receptor antibody, the one we're testing for, has had a very limited relationship with how someone is doing clinically. So you're right in that comment that's been told to you about there's not really a great relationship between the levels of the pathogenic antibody and your symptoms is correct. The reason it may work is because we don't know how MG works exactly. We know that is a useful diagnostic test, but there may be other immune players that are involved. And what this medicine does, and what plasmapheresis does, is just lower all the immunoglobulins that are of a certain type, IgG, so it doesn't lower other ones. And by doing that, we do know that people with MG do get better, and in many cases can stay better. So I think there's a gap there with our lack of understanding of the mechanism, probably because it's complicated. It's more complex than just lowering those myasthenia antibodies. There may be other immune aspects that are plasmapheresis. So that might be the answer.
Thank you. And my second question is, can you elaborate a little more on the benefits and risks of SCIG versus like more traditional treatments such as Imuran and Celsub?
Yeah, I should preface by saying that IVIG and subcutaneous immunoglobulin, especially subcutaneous immunoglobulin, are not really approved for chronic therapy in MG. So, sometimes we use it off-label, and that is something that we do because there's no other options. So, as I said, sometimes there's reactions to the traditional therapies. So we're really still testing that. But from what we do know about our experience with this in other conditions where it is approved, is that the subcutaneous immunoglobulin tends to have less systemic reactions. So for example, IVIG, when you get it, just to compare it to that treatment, is a very strong infusion into the vein, and there can be very severe headaches or more kind of systemic effects. When you give it subcutaneously, you don't do it every month at a high dose in the vein. You do it at low doses in the skin, under the skin, maybe once or twice a week. So the dose tends to be a bit lower, and so you don't get as many serious reactions or systemic reactions. The other idea behind immunoglobulin is that it doesn't lower the immune system in the same way that some of the other medicines do. For example, Imuran or azathioprine or prednisone, these really lower all the immune system aspects. IVIG tends to be what we call an immunomodulator. So it changes the immune system, but it may not lead to immunosuppression and risk of infections perhaps as much. And then, of course, there's very specific side effects to each different type of medicine. For example, azathioprine, you have to monitor the liver enzymes and the blood counts, and you don't need to do that or be as concerned about that with IVIG. So I think some of the risk profile is different. So I don't think it's all necessarily, favors one or the other. They're just different risk profiles. And comparing subcutaneous to IVIG tends to have a little bit better safety profile for systemic events. You may have more local events because you're doing infusion under the skin, usually in the abdomen. But that amount of redness, for example, or a little bit of swelling usually goes down after a few weeks of doing the treatment.
Okay, Sauvé.
Hi, thanks. I had a question when you were talking about the complement inhibitors and the idea that the complement's damaging that membrane. Does that reverse after treatment, that damage?
Yeah, great question. So these therapies, a lot of them, especially talking about the complement ones in particular, they need to continue to be given. And I think that is the challenge with a lot of these medicines, is that they work as long as you continue to take them. Similar to IVIG and similar to the FC receptor medicines, because they don't really shut off the production of the antibodies. They just either filter them out or block them or prevent the damage caused by them. So they're needed to be given every few weeks, or in some cases every few months, but you need to continue to take them in many cases. So once the treatment is stopped, that it is true that the pathology can return. So that is true that you may not shut it off, it may recur. So a lot of these treatments are ongoing chronic therapy.
Yeah, so just to kind of clarify, if you've, say, had damage to that membrane, would you expect with that treatment and with ongoing treatment that once the process had stopped, not only would it not continue to do more damage, but would it actually heal or return to how it was pre-MG?
Great question, because our understanding of complement damage, so the knowledge that complement is involved in myasthenia, it was known since the 70s when they were doing high kind of resolution microscope work. And the traditional thought was that it was kind of a more permanent damage to the junction. But because of all the information that we have now in the last decade or so, with complement therapy, we know that it may be involved earlier on. So it doesn't mean that once you have complement damage that junction cannot be fixed or restored. And that understanding really is a new thought. It wasn't really well known, and traditionally it was thought that it was a more permanent thing. And really our experience with that is more with people that have been untreated with myasthenia for many years, where that there's enough complement damage that really the muscle is really, really damaged beyond repair. But in most cases, we can repair the damage. And that's always our goal when we talk to MG patients, is as long as we get to it early enough, our goal is always to get you back to as well as you can be, nearly normal with the minimal amount of side effects in medicine. That's always the goal.
Thanks.
Okay, Marcia.
Hi, thanks. So, I'm wondering about Vyvgart is the one on the FCN, the ECU.
Yes, Vyvgart is one of the FCN. Yes.
Yeah. Okay. So currently, I'm taking methotrexate, along with we're trying to get me off of the prednisone. And my doctor was talking about switching me over to Vyvgart sometime in the spring. Is there an advantage to doing that? Is there a difference in the medication? I don't know what the benefits would be.
Well, I think certainly everyone is different, and if someone is already on a medicine, methotrexate or any of the other medicines, a lot of times one of the reasons to try some of the new therapies is to try to come off some of the other medicines. The biggest one is steroids, because steroids tend to have the most predictable and serious side effects if it's given at high doses for a long period of time. With the other ones like azathioprine or methotrexate or mycophenolate, a lot of times they don't tend to accumulate in the body or cause predictable damage or reactions in the body. So it's a good point that you have, that if you're doing well on a single steroid sparing agent, then the question is, will I be doing better than just on methotrexate, or will it allow me to come off of it if there's a concern about that medicine? So those would be the kind of questions to ask. And a lot of times we are switching people because there is issues with the existing treatments. But it's a good point. If there is no issues with the existing treatments currently or for the long term, then it may not be as appropriate, but everybody is different, I think.
Thank you.
Okay, Richard. Okay. I don't know if he's near his computer. He's muted. How about if we go to Livy Shaw?
Hi. Hi, so I actually do not have myasthenia gravis, but my mom does. So I am the one who is always in these meetings trying to learn as much as possible. So my mother has a pretty refractory form of musk myasthenia, and she is currently on mycophenolate, some prednisone, and she's recently started Truxima infusions. She's on her second infusion, so we're quite early on into this treatment. But one of the things that I wanted to know is she's on quite a few, immune suppressants. What do we have to worry about because she's on, multiple? What should we be concerned about and try to avoid? And should she be trying to wean off any of these immune suppressants? She has not had a lot of results from prednisone. She's been on it, for about a year now. And they're starting to wean her off, but she was having some more trouble with swallowing and then just overall mobility. And we've started the mycophenolate Mofetil about just over 6 months ago. And so we have not seen a ton of response yet, but we're not sure if we should still expect to see results. She started June 1st, so it's been quite a while. And obviously with Truxima, we're very, very new, so we just don't know what to expect yet. But should she be concerned about being on all three, and should we be trying to wean her off one of them?
I think ultimately that will be the goal, and that probably was the goal of starting the Truxima. And just to clarify for the group, Truxima is also a form of B-cell therapy, or I would use the word rituximab, but there's also other forms of it or other names for the medicine. So essentially she's on one of the B-cell therapies. And as I said, that tends to have shown good effects in musk myasthenia. So I think it is a natural choice to try. The challenge with some of the steroid sparing agents, including the mycophenolate that you mentioned, that is sometimes it takes a long time to take effect. In fact, for azathioprine, we often will tell patients that it could take over a year sometimes, and that's based on studies that were done many years ago that showed that sometimes even up to 18 months we see an effect. So it can be delayed. So in the case of your mother, I think it's certainly very early, because if she's only had 2 infusions of the Truxima, she's probably going to get the full infusion over this month to get the full dose. And that even then it can take a little bit longer to see the effects. But it's early enough that I think, the mycophenolate certainly could be reconsidered, because you're right.
Okay.
If you use 3 medicines, then the risk of infections goes up. But sometimes you need it. Like you said, if you try to lower the prednisone, for example, which is probably doing most of the heavy lifting right now, swallowing difficulties are a serious MG symptom. So you don't want to run into some risk there. So often it's the steroids that are the first ones we aim to drop in in your mother's case, I think it'll be up to, the treating physician and you guys to decide which one to drop and when, but certainly that would be the goal, I think, of the rituximab. So I wouldn't say the risk is excessively high, but certainly once you're on more than one, and if you're on 3 immune suppressants, the risk does go up. So you want to use precautions.
She also recently started IVIG as well because she had lowered IgG levels, and so they were hoping to sort of counter that a little bit. Is that, does that make sense to you?
Yeah, I mean, we don't usually, if it's used for that, that's usually under immunology for immune deficiency. And so that maybe the goal there may not be necessarily for NG. Sometimes the doses that are used for that are a bit lower. So I think whatever has been recommended, that's called secondary immunodeficiency. And so that may be what's going on there, but I don't think they would interfere.
Okay. Thank you.
Okay, Richard.
Hello, thank you. Do any of these treatments apply to ocular myasthenia? Or is ocular myasthenia sometimes considered like a whole different illness?
Yeah, great question. I think most of the new therapies I've mentioned are for generalized myasthenia. So for ocular myasthenia, it turns out that steroids, the prednisone, tend to be the best and fastest and most effective therapy. There was not really a lot of trials even for ocular myasthenia. We participated in one of the only ones that has ever been done in a big way a number of years ago, and it was very clear that the steroids worked very well. IVIG tends to be a challenging option. We've looked at some of our own data, and it's not that common to use it for ocular myasthenia. It just doesn't seem to work as well. Some patients are on it though. And really, when you start to look at the new therapies, eculizumab, the FC receptors, you are right. Those are all really quite restricted to generalized because they were tested in generalized in the trials. Now, that doesn't mean they don't work for ocular, but just hasn't been tested yet. And there is some trials and some smaller studies now that might be tried for ocular. So, in fact, I know there is some potentially that will be starting in the next year or two. So look out for that in case there's any of these new medicines that will be tried in ocular. Because to date, traditionally, it's not been available because it's been restricted to the generalized.
To generalized. Thank you.
Yeah.
Okay, Deirdre.
Hi, I'm Deirdre. I'm in Toronto, and in fact, Dr. Katzberg is my neurologist.
So,
I have MSc and I guess relatively there aren't so many of us. And then I know people in this group have they haven't found any antibodies, but they still have MG, so that's fun. I'll be seeing Dr. Katzberg soon, and I'm not going to ask personal questions about my personal treatment, but excellent slides. And I was wondering, there weren't a lot of treatments that you'd highlighted for MuSK. And, you made the application for me to get the one that you were highlighting. So, the slides are great. I'm just wondering if there's anything for MuSK or for seronegative that you want to talk about later. But the other thing is, I have obtained through personal contact a tiny bit of insight into how Health Canada deals with approvals for medications for rare diseases. And I'm going to say the good news is pharmaceutical companies love to run trials in Canada because the infrastructure is so fantastic. Unfortunately, Health Canada doesn't have, even when the trials have been run, it's up to the pharmaceutical companies to invest the resources, mostly time and, whatever costs are involved into making the application. And in very rare cases, usually with much older medications, Health Canada will say it's ridiculous that nobody's applying, we're just going to approve it. But with new treatments, those of us who have, in my case, a rare variant of an already rare disease in a country with a relatively low population base, don't expect it anytime soon. So Dr. Katzberg put in the application for my last appointment. He told me he was putting in the application in August, and here it is January, and it's just been approved. So, at least it was approved. I'm very happy about that. But and I'm sorry, I had to wake up from a nap for this, so I'm in my stumbling and mumbling phase of the days. I apologize, but I'm sure you're all used to it. I think in terms of there's nothing to compel the pharmaceutical companies that benefit from the fantastic resources we have in Canada to run the trials to actually then suck it up and make themselves and make the application for Canada. They'll apply to the EU, the US, Asia, anything but Canada first, because there's really no significant payoff. And, I've been so exhausted from MG, like as soon as I got the call Friday from Dr.
Deidre,
I'm babbling.
Deidre, this is
Okay.
not anything about what Dr. Katzberg's here to discuss.
Okay, I'll roll myself in. It's just I have so much trouble organizing my thoughts. It's sort of a policy issue. Anyway, I would encourage people here to, consider reaching out to their.
You make great points, Deirdre. So I think the issue of MuSK-MG, you're right, and also seronegative. I think those are two important populations. So for MuSK, we do use some of the steroids and other steroid-sparing agents in MuSK-MG, and I have many patients that are on those and doing well. So it's not always needed, but rituximab tends to have been, and those B-cell therapies tends to have been the ones that have the most effect. So I think there's a lot of momentum to continue on the B-cell therapies. So none of the new therapies, I think, because of the mechanism, are being necessarily considered. For seronegative, because we don't understand the mechanism as well, there is an effort to try some of these new medicines, the FC receptors and the complement inhibitors, especially the complement inhibitors. I think it's a challenge because it's thought to work in acetylcholine receptor antibody positive MG. Now, having said that, some of the FC receptor medicines are incorporating MuSK-MG patients as well as seronegatives. And then there's some studies that are just doing seronegative patients and MuSK patients alone. Those are smaller studies, not multi-center, usually done by one center. So I think there's going to be more coming out on it in the next few years, so stay tuned. And in terms of the access, I think you're right. There's a lot of practical issues relating to once it's approved and proven that the medicine can work. There's a lot of hurdles. So I agree, not just for the ones that have been around for a while, like rituximab, but for the new therapies as well. So I think we're all involved in advocacy. MG Canada, Muscular Dystrophy Canada, MG Society are very good advocates. So we're still we're always on the trying to support and advocate for patients. So we'll continue to do that with governments.
Okay, thank you.
Yeah.
Cheryl.
Hi there. I'm Cheryl. I'm in Ottawa. I have so many questions. First, you mentioned that rituximab. Sorry, my dog thinks we're talking to her. You mentioned that rituximab, once you've taken it, you have it in your system and it's hard to, how long does it stay in your system? How long do the effects last?
Well, one way to monitor that is by lowering or checking the B cell count. So that's what you're aiming to suppress. So a lot of times you can measure that. And what's been shown is that oftentimes B cell levels will stay down at least for a number of months. And as I mentioned, a lot of times that time frame is 6 months. So a lot of times we are reassessing treatment and using a 6-month mark. However, some patients may need this a little bit less than that and some a little bit longer than that. So it's variable by patient, but usually it is more of a sustained immune suppression than others. That's why I made that comment.
Yeah, see, it didn't, unfortunately, I didn't have any positive effects from it. It didn't help. But the doctors that I'm working with are keeping me on antiviral medications, and it's been almost 2 years because of the reduction in one's ability to fight infections after having had rituximab.
Yeah,
So
that's a good point. I think traditionally we don't do that as long, but they may have more insight perhaps by measuring your B cell levels. You know, as I said, everyone is different. So if there may be other reasons why someone may be on preventative therapy. And then, of course, there's the issue of perhaps if you're on other immune suppressants or your history or your
Yeah.
risk profile, you know, sometimes that's variable from patient to patient.
Now, if you fail one of those lines of therapy, whether it's the complement one or the fetal antibody one, is it likely that you will fail the next one in that line?
No, not necessarily. So that flow chart was not a sequential flow chart where, you know, you go from one to the other.
I don't mean sequential, but just if it's a B cell
Yeah.
that you failed.
No, not necessarily.
Okay.
No, and in fact, because they're all fairly different mechanisms, you know, there's very little relationship. There's not a lot of data on there on switching therapies because they're all fairly new. But no, there's no reason to think that you would not respond to one if you haven't responded to another one.
That's really good news. I just have kind of a small public service announcement on steroids. They're wonderful when they work, but if steroid sparing medication is available, it's really recommended. And if you haven't had a bone density test and you are on steroids, please ask your doctor for a bone density test. I've been on steroids for 7 years, almost 7 years, and I now have severe osteoporosis with 11 broken vertebrae and potentially 3 broken ribs in the last year. So as we're trying to come off the steroids, it's about looking for what's next in someone who's seronegative. So it's a tough juggling act for all of us, but I always want to just recommend everybody, because we're so focused on trying to feel better from our MG, we forget that steroids can cause some serious side effects. So Dr. Katzberg, I hope that you're recommending bone density tests for your wonderful patients who are on these medications.
So. Oh, I definitely agree. And I think with steroids, you're particularly at risk. In fact, all our neuromuscular patients, including, for example, muscular dystrophy patients that are not mobile, you know, if you're not moving around as much, your bones don't undergo the kind of the pressure that you need. So this is something we advocate a lot. And also with calcium and vitamin D, for example. And sometimes you need stronger prescription level medicines to manage the osteoporosis or the bone density issues. So certainly being aware of it is number one, and then targeting appropriate testing and treatment is also recommended.
Thank you so much for this. It's really appreciated.
No problem.
Kathy.
I'm one of the seronegative people, and I haven't had any antibody tests done since 2017. So I'm wondering if there's anything new after you've gone through the ACHR, MuSK, LEMS, LRP4, and cluster. Is there anything new in Canada since then?
Great questions. Nothing new in terms of antibodies. I think you're very up to date with the best antibodies, because that's often the biggest challenge, is that people do not do the cluster antibody, which is a little bit more sensitive. There's been maybe not a lot, but there's definitely patients we've picked up using that method, and that is has to be requested specifically on some requisitions to do this cluster antibody. The MuSK as well is a test that's important. The LRP4 is interesting because we're not sure the clinical relevance of it in all cases. I think the idea is that if it looks very much like MG and that antibody is clearly positive, there may be a relationship. But there's been a false positive scenario that we've encountered where LRP is also present in some cases that might look like myasthenia but are not actually myasthenia, more a non-specific finding. So I think we have to be a bit careful about that one. And all the other antibodies that have been talked about, in the setting of myasthenia, usually those are not clinically relevant, and can be more associated with thymus pathology and things like that. But no, there is no new MG antibody other than the ones you mentioned.
Thank you. I'm a very mild case. I've been on mestinon only for 11 years. So fingers crossed, whatever antibody I have, it's not doing a lot of damage. So thank you so much.
Yeah.
Okay, Livy.
Hi. So I had my mom write in a question. So she's having quite a few issues with swallowing. I mean, it's not to a point that we've had her go into the hospital or anything like that, but it's just like she's just very, very mindful of it because she knows it's a possibility. And she gets a lot of phlegm, and it's making it really, really like difficult when it comes to eating. She also has been experiencing kind of reoccurring batches of oral thrush, because she's on immunosuppressants. And so that really reduces what she's even able to eat. So she's finding quite a bit of weight loss, and just like, her options as to what she can sort of ingest are it's very, very low. So what would you suggest to try and mitigate swallowing issues, trying to reduce any like phlegm that she has? And also, like, is there anything out there that's not like an Ensure, where it's like a milk-based or sugar high product that she can kind of get some calories from?
Yeah, I think you're getting at a very important symptom in myasthenia, and that is what we call the bulbar symptoms, or the swallowing related symptoms. They're often a very great challenge to manage because they don't just flip back and forth as easily as, for example, the eyes or other symptoms. Sometimes it can take a while for them to swallowing muscles to get stronger. And then, of course, as you mentioned, there's all the other issues with thrush and things like that can affect swallowing as well. Some basic principles are, I think, and this we've learned over the years by working with SLP, speech and language pathologists, who often do the swallowing studies and then often give recommendations. And they're often working with nutritionists. And, for example, some of the things you mentioned are more related to making sure that there's enough calories that are have an intake. I'm not aware of any specific products, but things like Ensure or high calorie diets or supplements that can be used are helpful. The challenge, of course, is that when your palate is weak from myasthenia, thin liquids can be a challenge, come out the nose. So really, a lot of times the SLPs are recommending thickened type of foods and thickened kind of supplements that are safer to eat because they don't need to be chewed, and they're not thin enough that they regurgitate or cause risk of aspiration. So thickened kind of soups and thickened kind of foods, I think, are often the recommendation. Safe swallowing strategies, of course, chin tucks, taking longer to eat, and spending the time to get all the nutrition in. And a lot of times, though, this has to be done with professionals. So there's only so much I think sometimes patients can manage. So maybe getting some formal recommendations and having someone assess the swallowing. But I think the hope is, of course, that when the medicines start to work, that can start to get better and may not need to. That's something that can be that it can improve over time as well. So it may not be a permanent thing, but those are just some of the basic principles that we use.
Okay. Do you find that people go to nutritionists when they have myasthenia gravis to help work through, just making sure they're eating things that are helping their disease as opposed to making things harder?
Yeah, I think in some cases it can be helpful, especially if there's calorie related issues or other things where not getting enough nutrition. But a lot of times you can also get that information from the SLPs, speech and language therapists.
Okay. I actually have one more quick question, if that's okay. If, for example, her Truxima doesn't appear to be helping her, what would be the next, what should we look at next when it comes to medications? Would these FcRn inhibitors be something that we look at for a MuSK patient?
Those are still under investigation. So
okay.
Those are still being tested in some of the trials. Some of the newer FcRns are incorporating a group of MuSK patients. And there's some where it's still under debate whether it will be available for MuSK. For example, in Japan versus the US, for some of the newer FCs, there's variable approvals that have happened which have and have not incorporated the MuSK patients. So I think still remains to be seen, but I think it's probably one of the best chances of a medicine to work for MuSK is Ritux. So I would give it some time, and because I think there's a very strong chance it will work.
Okay, thank you.
Okay, Deirdre.
All right, this will be quick. Totally dumb question relating to the bone density scans. So years ago, I let myself be recruited into an inconvenient study around osteoporosis as a sort of sample healthy person. And my reward was that the team running it did a full body bone density scan, which is a really slow process. But my family physician has this fabulous benchmark for my bone density like 20 odd years ago. I'm hoping that 2 hours staring at the ceiling isn't required to get a sort of up-to-date look at what my bones are doing. But would up-to-date bone density scan be something I'd be requesting through my family physician?
Yeah, I think depends on the risk profile. If someone is not on steroids for an extended period of time and has no other risk factors, maybe less at risk. However, other things like age and other medical factors also weigh in. But I'm not exactly sure what the procedure is for the most up-to-date assessment. It looks like from the chat someone says about 30 minutes start to finish. So I think it's less involved than maybe that study. So yeah, it's something to talk about with the family doctor for sure.
Okay, thanks.
Okay, Tina.
This is Saga. So Dr. Brill is my neurologist, and I appreciate all the new updates. My question really, I guess, since we're talking about swallowing, is that I've been having swallowing issues for the last month. And the last month I've started Zopiclone. And I'm just wondering if that's a coincidence that I'm having swallowing issues now, or just very sensitivity in my throat, tightness, or could it be that there really is an exacerbation of my MG? That's,
good
I guess.
question. Good question. We always look at all medicines. Again, just as another public service announcement for the whole group, as many of you are aware of this, is that there can be interactions of medicines with MG. The most common ones being certain antibiotics. Another one being intravenous magnesium, particularly, not as much oral, but sometimes any sort of magnesium can also affect MG, often when it's given in hospital at high doses and fast infusion rates. And then there's a number of other medicines. So the basic kind of rule is to check, particularly if it's a new medicine, if you're wondering with resources. I know MG Canada has a very nice handout with the list in the back. And of course, some of the other MG societies and MGFA have resources on their websites. But Zopiclone does not tend to be one that we are as worried about in myasthenia. Of course, that is a sleeping kind of aid. And you want to be careful with any neurological medicine when you deal with MG if someone is very severe in a myasthenic crisis, for example, because you don't want to make someone maybe more drowsy and put them at risk for swallowing. But it tends not to necessarily worsen MG. So I would think it maybe would be less likely a contributor, and perhaps important to look whether the MG itself is causing the swelling.
Okay.
Okay, and can I do a part B?
Go ahead.
Sure.
Is there any sleep or antidepressant medications that you would recommend, or is that not part of this agenda for today?
I don't have anything more specific, but I mean, Zopiclone is a sleep medicine, and I mean there are other sleep medicines like clonazepam and things like that, but it's kind of the same thing. It's not necessarily known to worsen MG, and the same kind of safety principles apply.
Okay, thank you.
Just hang on a second. I don't know what your name is. Oh, John.
John.
for the list of medications that should be avoided or used with caution, that's the list that I believe you prepared, Dr. Katzberg. Am I right?
I'm not sure if I was involved with that one. It may have been a number of years ago, but I have seen the flyer and it's very good.
Yeah, well, what I was going to say, what I've been doing is when anybody gets their membership through MG Society of Canada, that is in the little welcome packet that I send out. But anybody that wants it, if you send me your mailing address, I will most gladly send it to you. Okay? Where did John, you had a question.
Hi, I'm John. I'm in Ottawa. I don't know how to phrase this question. Does one ever get off their medication?
That's a great question. So,
Because I'll give you the example. I went into crisis twice and I was hospitalized. I couldn't swallow. I couldn't talk. They loaded me up on prednisone, Imuron, and IVIG. That was about 3 years ago. So since then, I've got off of prednisone. I'm not on IVIG. I'm just taking Imuron.
Mm-hmm.
My neurologist thinks everything's going great. But should I say, can we go down a bit? Is there a risk of... I'm not sure how I'm phrasing this.
That's a great question. So I always say that when things are good and we're on medicine and we're making these decisions, that's actually the best place to be, because that's where we want to get to is making those decisions about whether you need the medicine or not. It's very challenging because we don't really have a marker like the blood tests we talked about earlier. Even doing the nerve tests, the electrical tests are not predictive always. We even did a research study once where we were trying to do PET scans to see if we can see who's active and not active to get more information on what you just asked. Can we come off the medicine? So there is not really any great way to tell if the MG is there under the hood, still active, and whether you need the Imuran or not, or the azathioprine or not. So a lot of times it's a trial and error. And so a lot of it depends on your history. For example, if you've had 2 crises and you had all these medicines, that generally the thought is that because what we know that Imuran does take some time to work, and because it takes some time to build up, that we tend to keep people on those medicines if they're not causing problems and if someone is stable, just because if someone's had a lot of active MG in the not too recent past. Now, having said that, there is situations where one can taper the medicine, even Imuran, and I've spoken to our other MG colleagues in Canada and around the world, and I think many of the MG experts will lower Imuran a bit. It tends not to be one that we can titrate like prednisone, where we really go up and down, very variable doses, but there is something to lowering Imuran a bit. But if it's not causing problems, then the same risk occurs where you might lower it to a point where it's not working and you can have a MG exacerbation or crisis again. So it's all about kind of the risk benefit and the patient's history. Okay. But the short answer is yes, you can taper and you can go off these medicines, but it's all about the risk of relapse and whether it's worth going through that or not.
I go every 3 months for blood tests for whatever it is he's testing, liver or whatever.
Yeah. I think in your particular situation, I'm not surprised they've kept you on it just because of your not too distant crises. And now that the Imuran is working, I think maybe leaving things in a stable way, if it's not causing problems, is worthwhile.
Okay.
Okay, Francine.
Just to let you know that I was for about a year considered under remission with medication. At that time, I was at 5 mg of prednisone and 3 times methadone a day, the 60 milligram. And last December, I had a flare. We still don't understand why, which is basically confirming what you are saying. I was for 7 months on 5 mg. I was on 7.5 for about a year and a half. It may be just the drop of 7.5 to 5, plus some stress, plus other things. So now my doctor increased it to 30 milligram, increased my prednisone to 4, and I'm on IVIG. And at that time, I had difficulty swallowing, difficulty speaking. To be honest, after 2 weeks of the high prednisone at 30, and after a treatment Spiridon 2 of the IVIG, I now no longer have, after a month, any difficulty speaking, and the swallowing is fine. I still am tired and I've got to do things, but in terms of the effect of the prednisone and the IVIG, it cleared the friend.
Yeah, I think
You know, right now we're just going to lower down the prednisone slowly, combined with the IVIG, and then my doctor said, I don't think we'll go down to 5 yet.
Yeah, you make two good points from that. Is that when you start to get on the low doses of prednisone, like 5 or less, around there, sometimes even low doses can make a big difference. So sometimes we will not drop it to 0, or we will go very slow at the lower doses compared to when we were dropping from the higher doses. So that's exactly right. And then the other issue, of course, is that, you know, there can be, MG is a very variable disease. Sometimes there's no reason why someone will exacerbate. Sometimes it's infection, sometimes it's stress. A lot of it tends to happen around December. I made a comment online about this, that December is a tricky month for MG because there's, you know, infections and it's a difficult time. So we have to be particularly attuned. But you're exactly right. I'm glad you're better.
Thank you.
Okay, Deirdre.
I'll be quick. I'm so thrilled to hear that some of you have gotten to the point where you're close to consider, like, asking, when can I stop? And I'm so thrilled that you've been in remission. A loved one of mine had a form of epilepsy, and when it was time for her to consider going off the medication, a real risk factor was that if she went too low and seizures returned, that specific medication might never work for her again. Is MG a completely different kind of sandbox in terms of risks of ceasing medication?
Yeah, I think so. I think, you know, if you don't respond to a medicine, it's probably less likely that you will respond. And same thing with MG, but not necessarily. And it's not the same. And there's much more options, I think, for epilepsy in terms of anti-seizure medicines. So I think general principle applies, but not necessarily in every case.
Thank you.
Okay, Livy.
Hi. So for rituximab and biosimilars, how long does it typically take before you start to see some results? I know it's different for everyone, but just as like a benchmark of hope, what is it? Where do you normally start to see results?
It tends to be quick, quicker than most. So we've seen people who have responded even after the first couple of treatments as early as that. So sometimes that, you know, and we've had to deal with this in the pandemic. Even, you know, we were trying to not have people in hospital, and there were some people after 2 treatments, they got well enough that we discharged them because we didn't want them to be around all the COVID patients. So I think it can work fast, but sometimes it does take a bit longer. Certainly you want to wait till all the 4 treatments are done. That usually takes a month. And then even after that, there could be a bit of, full effects that's still to come after that. So tends to work fast, but, you usually want to give it a little bit of time after the last dose to see the effects.
Okay. And one other question I had is managing anxiety. I know anxiety can be a major trigger for myasthenia gravis. My mom is a highly anxious person. Do you find that a lot of your patients go on anti-anxiety medication if they are a very anxious person, just to try to mitigate, the effects from high levels of anxiety?
Not necessarily. I think certainly it's important to address all those issues, mental health issues, whether it's anxiety or depression. It's just important to, work with whoever's prescribing it. And usually it's not the neurologist that prescribes those just to make sure it's safe and there's no interactions. But certainly, if it's interfering with the medical condition, it's a good idea to go on therapy if that's what's going to help. So yeah, I don't think that there's a reason you cannot. If that's needed, I would recommend it.
Okay, thank you.
Okay, I've got my hand up, so I'm going to ask a question. You were mentioning about the Rituxan or rituximab being done like once a week for 4 weeks. Is that a new way of doing it? My neurologist has me on it, and it's 1 dose, and then in 2 weeks it's another dose, and then nothing for 6 months. So is this a new way, or is it just everybody does it different?
I think it's done differently. That's one strategy, the one we mentioned. But yeah, I have seen the every 2-week strategy as well. There's also been some trials, as I mentioned, that have used a low dose of rituximab more frequently. So that's a new strategy, but that's come more recently in the last few years. But traditionally, it's either every week for a few weeks or higher dose maybe, but less frequent, with still that interval. But no, I've seen both strategies.
Oh, okay. Thank you. Okay, Cheryl.
You mentioned that as the prednisone dose decreases, you have to kind of watch things more closely because each milligram might make a lot of difference. So at what rate do you recommend decreasing if the goal is to get off completely? Is it a milligram a month, or, what is your suggested rate? And I mean, symptoms might get worse, but when is that a concern? Like a little bit of symptoms, is that okay? Or, how do you weigh that?
So this is what we do every day as neuromuscular doctors, and same thing with rheumatologists, that are managing lupus and other conditions where steroids are used. And it also it's disease dependent. So myasthenia is different than lupus, than rheumatoid arthritis, for example. And then also there's different strategies that people use. So for example, you don't always taper by milligram necessarily. In our practice, we a lot of times will taper by 2.5 milligrams, which is half of the 5 milligram tablet. So 1 milligram a month is very, very slow, very conservative. So you don't always taper that slowly, but everyone is different, I think. So that's the part where, the more, the frequent touch points with the treater and the physician, and making sure that it's appropriate for you. And a lot of it depends on what's happened recently, what's happened in the past as well. So I would say 1 milligram a month is very low or very slow. Typically we go a little faster than that, but and not always by 1 milligram tablet. But 2.5 is also another reasonable way to do it slowly, because you can do it in smaller decrements. There's also an alternate day dose that can be used to titrate more slowly. So instead of doing 5 milligrams every day, you would do 5 and 4, 5 and 3, 5 and 2, or 10 and 9, 10 and 8. So that's another strategy sometimes that's used to do a slower taper.
That's helpful. And then, how much symptom is okay? Like mine is very much bulbar. It's swallowing, it's speaking, it's, my facial muscles. And I've had it and I've been managing it for years.
Yeah.
And it's never gone. But how much is okay? Like, if you can't get rid of it.
Yeah, one goal that we often use is a minimal manifestations, meaning if the symptom is there, you notice it, but it's not interfering with your function, interfering with your daily life to a great degree. That's often a target. We've also, in our clinic, we will ask patients, do you find your current state acceptable or not? We call it PASS, P-A-S-S, Patient Acceptable Symptom Score. We'll also ask patients on a percentage, 0 to 100%, where do you feel you are? And that's what we ask patients every time. And we'll often use those to get feedback from patients, how they're doing, So it's more than just what we see on the exam or on those scores. And that will often kind of break the tie on whether we should change medicines or not. So a lot of times it's what you feel.
Okay, I think we've got one more question and then I think we will wrap it up. So, Sylvain?
My question was just kind of in the same in the same neighborhood as yours, Linda, of course, because we're basically sharing a brain at this point. I'm also on rituximab and was curious about the different dosing schedules and what would make the decision between one dosing schedule versus another one. Mine is actually being prescribed by my rheumatologist because I have multiple comorbidities happening at the same time. So it's treating multiple things, but.
Yeah, I think rheumatologists and neurologists tend to have a little bit different strategies. A lot of times the strategy that's used by the specialty will depend on, for example, what was used in certain clinical trials. So just try to mimic that. But I think if you look at the dosing itself, whether it's spread out over 4 weeks at lower doses or given at a bit of a higher dose less frequently every 2 weeks, it usually works out to the same. So I wouldn't be concerned about those differences. I think many of the rituximab strategies work, no matter how they're given, as long as it's safe. And obviously there's a limit to how much you can give all at once or with frequent dosing. So we don't tend to do it more than every 4 months, for example. That tends to be a bit too much immune suppression. But short of that, I think there can be variable dosing strategies.
Okay, thank you.
Okay, on behalf of the Myasthenia Society of Canada and the board members, we want to thank you, Dr. Katzberg, for taking time out of your busy schedule to talk to us. We're going to wrap it up. Before I go, if anybody's interested in that medication card, if you send me an email to linda@mgcanada.org with your mailing address, then I can send it to you. Okay? So again, thank you, Dr. Katzberg. Hopefully we can convince you to do it again.
Of course.
Thank you.
I'm always happy to meet with your group. So thanks, everyone. Nice to see you all.
Thank you so much.
Thank you.
Thank you, Dr.
Thank you very
Katzberg.
much.
Bye-bye.